Hello and welcome. We are delighted to have you with us for continuous learning with Bioguard. It is my pleasure to introduce today's webinar speaker, Dr. Shi Chiou. Dr. Chiou earned his master's degree in veterinary pathology from National Taiwan University and is a certified veterinary pathologist in Taiwan. Sorry. He brings extensive expertise in diagnostic, surgical, and laboratory animal pathology, and currently serves as a pathology specialist at Bioguard Corporation. As we know, IBD is a common cause of chronic gastrointestinal signs in dogs and cats, yet diagnosis and management remain challenging. Intestinal biopsies remains the cornerstone of diagnosis, though histopathologic findings can be difficult and to interpret. In this webinar, Dr. Chiou will discuss clinically relevant approach to interpreting biopsy results, highlight key lesions associated with disease severity, and examine the practical value and limitations of histopathology in everyday clinical decision making. Without further ado, please join me in welcoming Dr. Chiou.
Good evening, everyone. Thank you, Dr. Low. And can you see my screen and hear my voice?
Yes.
I think I'm sharing the PowerPoint right now. Did you
Yes.
see the PowerPoint? Okay.
Yeah,
Okay.
yes.
Okay. Hi, everyone, and thanks for joining today's webinar. And during the presentation, I think I should turn. Okay, never mind. Today, the topic we are diving into is inflammatory bowel disease. What is the pathology really tell us in clinical practice? I'm Chu, a veterinary pathologist, and I'm glad to have you here. Over the next hour, we'll talk about some key ideas about histopath in IBD. Whether you are in clinical work, diagnostics, or research, I hope today's session gives you some practical takeaways you can use in your own work. This webinar presentation is made by the reporter according to the pathology specialty. The report only contains pathological professional content and can respond to any questions about other clinical issues or therapy. So if you have any comment or questions, please leave your message in the QA or message box. The content of this presentation is entirely based on this study. If you would like to learn more detailed information, please search this article from the website for further reading. This webinar is held by Bioguard Corporation. Bioguard is a company based in Taiwan, provide accurate diagnostic tests in many diseases. So if you are interested, please follow Bioguard on Facebook or LinkedIn for more information. Here's a little about me. I'm a veterinary pathologist. We focus on surgical pathology, lab animal cases, and diagnostic pathology. Before we talk about disease, we need to remind ourselves what normal looks like. The intestinal mucosa is not just a layer of cells. It's a highly organized immune organ. We have a villi architecture here, and a crypt structure, and lamina propria here, and some lacteals, and enormous immune cell population. Even in normal dogs and cats, the intestine is full of lymphocytes. So when we say lymphoplasmacytic enteritis, we must ask, how much is too much? And that's where interpretation becomes challenging. Inflammatory bowel disease, IBD, is a syndrome despite being called a disease. IBD is caused by a specific reaction to chronic irritation of the GI tract. Inflammation is the body's response to an insult, injury, or foreign substance. With IBD, specific types of inflammatory cells, depending on the type of IBD, invade the wall of the stomach or the intestine. As inflammatory cells invade the lining of the GI tract thickens, this thickening makes it harder for animals to absorb nutrients and move food along the GI tract. IBD is microscopically described as lymphoplasmacytic to eosinophilic enteritis. Diagnosis is by biopsy, not by clinical signs alone. But here's the key issue. We still don't fully understand the cause of the disease. The predominance of lymphocytes and plasma cells strongly suggest immune dysregulation. In dogs, both B and T cells are increased in the lamina propria, and when infiltration becomes marked, we start seeing malabsorption, protein loss enteropathy, hypoalbuminemia. But the question is, does the number of inflammatory cells directly correlated with clinical severity? We see the answer is not always. When we say the lamina propria is widened with lymphocyte and plasma cells, what does that mean biologically? It means immune activation, but widening doesn't tell us how chronic the disease is, how deep the injury goes, and how severe the clinical signs will be. Inflammatory cells numbers are the only part of the story. I think everyone in this room has experienced this. Chronic vomiting and diarrhea, and the biopsy says mild lymphoplasmacytic enteritis. And you think, really? There's often variable biopsy results, inconsistent correlation with severity, unpredictable response to therapy. That's why IBD is frustrating. It's not just because histopath is useless. It's because we are asking it the wrong question. IBD is not one disease, it's part of the chronic enteropathy spectrum. It's a diagnosis of exclusion, and it's also multifactorial. Immune dysregulation, microbiome imbalance, barrier dysfunction, and genetic predisposition. So when we look at the histopath, we are seeing only the biologically injury, not the whole pathogenesis. So pathology answers the three main questions. Is there inflammation? What type of inflammatory cells are present? Is there structural damage? Inflammatory patterns may include the lymphoplasmacytic, eosinophilic, neutrophilic, or mixed type. However, simply detecting inflammatory cells doesn't quantify disease severity in a clinically meaningful way. The more clinically informative aspect often lies in structural changes, which reflect chronicity and remodeling. When is biopsy clinically useful? Biopsy is not always necessary in early chronic GI disease. Many patients improve with diet modification or a short antimicrobial trial. If they respond, we may not need to scope at all. But biopsy becomes important when red flags appear, like if signs persist despite reasonable trials, if you suspect small cell lymphoma in cats, if hypoalbuminemia develops, or if the patient continues losing weight despite therapy. In this study, the dogs were biopsied only after failing diet and antibiotic trials. That means the histopath truly reflected idiopathic IBD. So the message is simple. Biopsy should not be routine. It should be strategy. However, one very important finding from this study was that histological scores correlated significantly with clinically activity in the duodenum and colon, and not in the stomach. In other words, gastric biopsy may be much less informative when we are trying to assess IBD severity. The correlation was moderate for duodenum and colon, not perfect but meaningful. The stomach, no significant correlation. So this tells us something practical. Sampling location matters. If the clinical picture suggests small intestine disease, prioritize the duodenum. and ideally include the ileum. If the signs are large intestine dominant, then colon becomes critical. Because good pathology interpretation doesn't start under the microscope, it starts with appropriate sampling. The simplified scoring system divides histological changes into two main categories: inflammatory changes and morphological changes. On the inflammatory side, we look at laminar propria lymphocyte plasma cells, eosinophils, and neutrophils. On the morphologic side, we assess structural damage like villi stenting, crypt dilation, lacteal dilation, surface epithelial injury, and fibrosis. Why is this separation important? Because it improves reproducibility between pathologists. And more importantly, it improves clinical correlation. It reminds us that structure and information are not the same thing, and sometimes structure tells us more. In the simplified scoring system, inflammatory cell density is graded in a semi-quantitative way. So we are estimating how many lymphocytes, plasma cells, and neutrophils are present, not counting every single cell. But here's something important. An increased lymphoplasmacytic infiltrate alone doesn't always strongly correlated with clinical severity. In this study, laminar propria lymphocyte and neutrophils in the duodenum, they show significant correlation with clinical index. However, the correlation was only moderate. So what does that mean? It tells us that inflammation does contribute to disease severity, but it doesn't fully determine it. In other words, more cells doesn't automatically mean worse clinical size. Structural parameters may actually reflect chronicity than acute inflammation. For example, villi stenting usually indicates prolonged mucosal injury. Crypt dilation can reflect regenerative stress or architectural distortion. And fibrosis tells us that remodeling has already occurred, meaning this is not an early lesion. So these are not just microscopic details, they are markers of time and depth of injury. In this study, villi stenting and crypt dilation showed significant correlation with clinical disease activity. That's important because it suggests that structural remodeling may be more clinically meaningful than inflammatory cell density alone. In simple terms, structures often tell us how long and how deeply the disease has been active. This slide shows how we grade laminar propria lymphocytes and plasma cells, which is essential for evaluating chronic enteritis and IBD. In normal mucosa, inflammatory cells are sparse, occupying less than 25% of laminar propria, with only 1 to 2 cells between each group crypts. With mild increase, they expand to 25 to 50%, and small clusters begin to appear between crypts. In moderate inflammation, cells are occupied 50 to 75%, and crypts are more clearly separated by inflammatory cells. In marked cases, the laminar propria is densely packed, 75 to 100%, with significant architectural disruption. So the key is not just the presence of cells, but their density and impact on tissue structure, which help us grade disease severity consistently. This slide shows villi stenting, another key feature when assessing intestinal inflammation. In normal mucosa, villi are long, slender, and uniform, indicating a healthy obstructive surface. Proper orientation is important for accurate evaluation. With mild stenting, villi are shortened about 75% normal length and may appear slightly wider and irregular, but the overall structure is still preserved. In moderate stenting, villi are reduced to around 50% of normal height, becoming broader, and some may start to fuse, indicating more significant mucosal injury. In marked sounding, villi are severely shortened or even fused, and the surface may appear flattened, like this. So clinically, villi sounding reflects loss of obstructive surface area, and when combined with inflammatory cell infiltration, it strongly supports corneal enteropathy or IBD severity assessment. This slide demonstrates crypt distinction, which reflects epithelial injury and active inflammation. In normal mucosa, crypts are uniform, straight, and narrow, aligned perpendicular to the surface with minimal luminal content. With mild distension, up to 10% of crypts are become dilated or distorted and may contain eosinophilic debris or inflammatory cells. In moderate cases, up to 25% of crypts are affected, with more obvious dilation and frequent crypt abscess. In marked distension, up to 50% of crypts are involved and showing severe dilation, distortion, and abundant inflammatory debris, indicating significant mucosal damage. So overall, crypt distension is a useful indicator of active epithelial injury and inflammation, especially when neutrophils and crypt abscess are present. This slide shows lacteal dilation, which reflects lymphatic dysfunction and is often associated with protein-losing enteropathy. In normal mucosa, the central lacteal occupies about less than 25% of the villi width. With mild dilation, it expands to around 50%, and villi may appear slightly wider. In moderate cases, the lacteal become ballooned here, like this, occupying up to 75% with clearly within the villi. In marked dilation, here you can see the dilated lacteals. They occupy nearly the entire villi, often with edematous lamina propria and club-shaped villi. So lacteal dilation is a key feature indicating impaired lymphatic drainage, and clinically it raises concern for intestinal lymphangiectasia or protein loss. This slide is mucosal fibrosis, which reflects chronicity of crypts are separated by a thin stromal layer. With mild fibrosis, there's a slight increase in stromal tissue, with crypts are separated by a wider band of fibroblasts. In moderate fibrosis, the stroma becomes more prominent, with further separation of crypts, and some may appear atrophic or irregular. In marked fibrosis, there is extensive collagen disposition, with crypt widely separated, atrophic, or even lost, and replaced by fibrotic tissue. So mucosal fibrosis is an important indicator of corneal long-standing disease and helps distinguish corneal enteropathy from acute process. Okay, clinical severity reflects functional consequences, things like motility disturbance, secretion imbalance, malabsorption. These are functional problems. So, on the other hand, structural changes reflect biological injury. So we're actually looking at two different domains. They overlap, but they are not identical. In the study, the summative histopath scores show significant correlation with clinical disease activity in the duodenum and colon. That supports the idea that when structural damage accumulates, clinical impact tends to increase, but the correlation was not perfect, which reminds us that histopath is only one component of a multidimensional disease process. It contributes to the picture, but it doesn't define the whole picture. Before the simplified scoring system was introduced, most of us were using the Wasava GI standard guidelines. It was the standard reference, but over time, multiple studies show something concerning. There was significant variability among pathologists. Two pathologists could look at the exact same biopsy and assign different severity grades. If the grading is inconsistent, then any correlation with clinical index becomes unreliable. So the question becomes, is histopath truly poorly correlated with clinical disease, or is the grading system the problem? The study proposed something important. Maybe we need to simplify the scoring system, focus only on parameters with better agreement between pathologists. That was a critical conceptual shift. The issue may not have been that histopath was meaningless, but that our grading lacked consistency. So how did the simplified system actually work? Instead of scoring everything, it selected only 3 to 5 key histological features for each GI region, specifically the ones that show the best agreement among pathologists. Each parameter was graded on a simple 0 to 3 scale, 1 minimal normal, 1 is mild, 2 is moderate, and 3 is marked. Then those scores were summed to create a regional histopath score that allow researchers to analyze correlation between histological severity and clinical index. And here's the key point. By simplifying the synthesizing the system, reproducibility improved. And once reproducibility improved, meaningful clinical correlation began to appear. So what did the study actually show? When they look at the summative histopathologic scores, they found significant correlation with clinical activity in two regions, the duodenum and the colon. The ileum show a near significant correlation, but stomach, no significant correlation with clinical severity. Now, these numbers are not perfect correlations, but they are meaningful. And more importantly, they have practical implications. If we want clinically relevant information from biopsies, sampling the duodenum, and ideally the colon, give us more value than taking gastric samples alone. So again, location matters. Where you biopsy can determine how clinically useful the pathology report will be. Beyond the overall summative score, the study was also look at individual histological parameters, and some specific features show significant correlation with clinical disease activity. For example, villus stenosis reflects mucosal atrophy, strip dilation indicating architectural distortion, mucosal fibrosis is a marker of chronic remodeling, increased laminar propria neutrophils suggesting active inflammation, and lacteal dilation indicating lymphatic involvement. So what does this tell us? It suggests that both chronic structural injury and active inflammatory components contribute to clinical severity. In other words, it's not just about how many lymphocytes are present. It's about how much structural damage has accumulated and whether active inflammation is ongoing. But again, the correlation was moderate, not strong enough to precisely predict how severe the symptoms will be in the patient. Histopaths inform us, but it doesn't function as a symptom scale. Another important point from the study is this. Not all inflammatory parameters are equally clinically meaningful. For example, intraepithelial lymphocytes did not show strong correlation with clinical severity. Some eosinophil counts showed only limited association, and gastric inflammation had minimal clinical correlation at all. So what does that mean for us in practice? It means that a mild increase in certain inflammatory cells doesn't automatically translate into significant clinical disease. Not every elevated cell count should trigger aggressive intervention. And again, this reinforces two key ideas. Location matters, and structural injury often matters more than isolated inflammatory cell numbers. So when you read a pathology report, focus on the big picture, not just one cell type. When we talk about clinical size, things like diarrhea or vomiting, they're influenced by many functional factors. like motility changes, secretion imbalance, microbiome interactions, neuroimmune responses. They are dynamic functional process. Histopath, on the other hand, reflects something different. It shows us silver infiltration, architectural distortion, chronic remodeling. So we are actually looking at two overlapping but distinct domains. And that explains something we all see in the practice. The patient may have severe diarrhea, but only mild histological changes. Or the opposite, significant structural damage on biopsy, yet relatively moderate clinical size. Because histopath is not a symptom scale, it reflects biological injury, not how dramatic the symptoms appear. In early disease, or in cases where functional disturbance is the main driver, hero size can be quite severe, even when structural damage is still limited. On biopsy, you might only see mild lymphoplasmacytic infiltration. The villi architecture may still look intact. No obvious fibrosis, no marked distortion. And that can feel confusing. In these cases, the problem may be more functional than structural. So management should focus on moderating the immune response, stabilizing the microbiota, and restoring barrier function, rather than interpreting a mild histological score as a mild disease overall. Because again, histological severity doesn't equal clinical severity. In some patients, especially those with long-standing disease, fibrosis and villi swelling can persist even when the clinical signs are partially controlled. So the patient may look stable, appetite is okay, diarrhea is improved, but under the microscope, structural remodeling is still there. Because structural repair often lags behind the clinical improvement. And this helps explain something important. Histological severity doesn't always mirror current symptom intensity. Sometimes we are seeing the scar of the past injury, not the activity of the present moment. In those with protein-losing enteropathy, structural changes become especially important. Findings like lateral dilation, significant villi damage can directly contribute to protein loss. In the study population, some of the more severely affected dogs show hypoalbuminemia, even ascites. Now, can histopath precisely predict albumin level? No, not exactly. But when we see structural abnormalities that disrupt mucosal integrity, that raises concern because those changes suggest impaired barrier function and lymphatic drainage, which can have prognostic implications. So again, structure matters, especially in protein-losing enteropathy cases where structural integrity directly affects protein balance. We also need to remember the limitation of endoscopic biopsy. Endoscopic samples only include the superficial mucosa. So if there is transmural disease or deeper infiltration, we may miss it. IBD lesions can also be patchy, so sampling error can lead to underestimation. In the study, poor quality samples were excluded to maintain reliability. But in real clinical practice, we don't always have perfect samples. Orientation issues, crushed tissue, insufficient depth, all of these can limit interpretation. So whenever you read a pathology report, you must interpret in light of sampling limitations, because sometimes what we are seeing is not just the full picture. It's just the part we are able to sample. Most of the data we have on histological clinical correlation actually comes from canine studies. The simplified scoring system was validated in dogs but not in cats. and that distinction matters. In dogs, the correlation between structural lesion and clinical index is moderate but measurable. Prognostic associations are somewhat clear. But in cats, things become more complicated. Histologic patterns often overlap with small cell lymphoma. Clinical severity doesn't always parallel histological grade, and diagnostic gray zones are much more common. So when interpreting feline biopsies, we need to be even more cautious. What looks like marked lymphoplasmacytic enteritis in a cat may not behave the same way as in a dog. Species matters, and uncertainty is higher in feline cases. In cats, one of the biggest challenges is distinguish lymphoplasmacytic enteritis from early small cell lymphoma. Histologically, they can look very similar, but both may show increased small lymphocytes within the membrane, only mild architectural distortion. So under the microscope, the difference may not be obvious. So what might help us? Features like epithelial tropism, a more monomorphic lymphocyte population, clonality detected on PAR PCR, or specific immunophenotypic patterns on HC. But even with these tools, some cases remain borderline. And that's the key point. Histopath alone may be insufficient in certain feline cases. Sometimes the diagnosis become clear only after overtime, through clinical progression, imaging changes, or response to the therapy. So in cats, interpretation is often probabilistic. It's not always a single biopsy that gives us the final answer. In feline cases, there are certain situations where we should raise our level of suspicion. For example, if the biopsy reports marked lymphoplasmacytic enteritis, but the clinical signs continue to worsen despite immunosuppressive therapy, and imaging shows focal intestinal thickening, that combination should make us pause. In those cases, it may be appropriate to pursue additional diagnostics, such as CD3 and CD20 HC stain or PCR for PAR. These tools don't replace histopath, but they increase our diagnostic confidence, especially when we are trying to distinguish inflammatory disease from early neoplasia. Because in cats, that line can be very thin. The Simplified scoring study did show correlation between histopath severity and clinical activity at the time of diagnosis. But we need to be careful here. Histopath alone doesn't reliably predict long-term outcome. Certain structural features like fibrosis or severe villi shortening may suggest chronic, long-standing disease. The prognosis is much more complex. The prognosis depends on albumin levels, response to therapy, body condition, and whether systemic complication develop. So while histopath inform us about severity at the tissue level, it doesn't directly translate into survival probability. A severe biopsy result doesn't automatically mean a poor outcome, and the mild biopsy result doesn't guarantee an easy course. Prognosis remains multifactorial. In many chronic inflammatory disease, histological remission lags behind clinical remission. So you may see clear clinical involvement, better stool quality, weight gain, improved appetite. But if you biopsy again, architectural distortion may still be present, because structural remodeling takes time, and sometimes it doesn't completely resolve. That's why repeat biopsy is not routinely necessary in clinical stable patients. Histopath is most useful for initial diagnosis or for reassessment when the disease behavior changes, not as a routine monitoring tool in every improving cases. Rebiopsy is not routine in stable IBD cases. If a patient is clinically controlled, eating well, maintaining weight, there's usually no need to scope again. But there are situations where we should reconsider. For example, if a dog with chronic IBD suddenly worsens, if a cat that previously responded to steroids stops responding, or if imaging reveals new focal intestinal lesion. In those cases, re-evaluation may be warranted, especially in cats, because progression from inflammatory disease to lymphoma can occur in cats. So the decision to rebiopsy is not protocol-driven. It's driven by clinical judgment. When you read a pathology report, try not to focus only on the inflammatory terminology. Words like moderate lymphoplasmacytosis can sound dramatic, but they don't tell the whole story. Instead, ask yourself a few practical questions. Is the villi architecture preserved? Is there crypt distortion? Is fibrosis mentioned? Are the lesions diffuse or focal? And were all clinically suspected lesions actually sampled? Because location matters, and severity grading should always be interpreted in the context of patients sitting in front of you. The pathology report is part of the puzzle, not the final answer. Okay. These 5 questions can completely change how you use a pathology report. Instead of reading it as a descriptive document, you start using it as a clinical decision-making tool. It shifts from what did the microscope see to how does pathology report change what I do next? And here's something worth reflecting on. If the answer to that 5th question is no, if the biopsy result doesn't change your management plan at all, then either the biopsy was not necessary or our expectations were misaligned from the beginning. Because a biopsy should add value. If it doesn't influence decision making, we need to reconsider when and why we are using it. Let's consolidate the major conceptual shifts from today. First, histopath is meaningful, but it's not absolute. Second, structural damage tends to correlate more consistently with clinical index than mild inflammatory infiltrates alone. Third, gastric biopsy by lymph cells are usually insufficient in most IBD cases. And perhaps most importantly, interpretation must always integrate multiple domains, include clinical signs, lab findings, image results, and response to therapy. Because pathology informs, it doesn't dictate. The biopsy adds biological insight, but clinical judgment remains central. The most productive way to view biopsy results is to see them as corroborative data. Pathology answers certain specific questions. What type of inflammation is present? How severe the structural damage? Is there evidence of neoplasia? That's our pathologist's role. But clinicians integrate something different. How severe are the functional signs? What is the systemic impact? How is the patient responding to therapy? When these expectations are aligned, when we understand what pathology can answer and what it cannot, histopath stops being a source of frustration, and instead it becomes a powerful clinical tool. Because it's not about replacing clinical judgment, it's about supporting it. Let's put everything together. This slide shows what chronic inflammation can look like when it progresses to severe clinical disease. This dog is Caucasia. You can see accentuated ribs and muscle due to loss of subcutaneous fat and abdominal fat. On endoscopy, the intestinal mucosa show granulation, irregular surface compared to normal intestine, smooth and uniform. So even closely, we can see architectural alteration. Now moving to the histopath. This is duodenum mucosa. The lamina propria is expanded by lymphocyte, plasma cells, and macrophages. The villi are widened. Enterocytes appear more cuboidal, and globular cells are reduced. This reflects both inflammation and structural change. Here we can see dilated crypts containing neutrophils and cell damage. That suggests active epithelial injury there on the top of chronic inflammation. Here we can see diffuse infiltrates of lymphocyte and plasma cells in the lamina propria. And these two images show the HC for CD3 and CD20. Though we can see the mixed type of lymphocyte populations. So it's a inflammatory enteritis, not a neoplasia. Now let's look at what IBD can look like endoscopically. In image A, here we see increased small intestinal viability. The mucosa appears fragile. It bleeds easily. This suggests active inflammation. Image B, there is increased granularity of the small intestinal mucosa. The mucosa look uneven, almost sandpaper-like. Granularity often reflects mucosal infiltration and architectural disruption. Image C here, we see mucosal erosion. This indicates more significant epithelial injury, which can contribute to protein loss and malabsorption. In image D, we can see that this shows the biopsy forceps to obtain partial thickness mucosal samples. This is the reminder of something important. Endoscopy biopsy samples only the superficial mucosa. We're not seeing the muscle layer and transmural involvement. Now let's look at some actual histological examples from a dog with IBD. From figure 1, the stomach, specifically the antrum. Here, within the lamina propria, you can see multifocal glandular atrophy. Normal glands are reduced, and in their place, we see metrofibrosis. This is not just inflammation. This is structural remodeling, such as chronicity. And figure 2 is the duodenum. Here we see diffuse moderate blunting and shortening of villi. The villi profiles are clearly atrophic. They are not tall and finger-like anymore. Again, this reflects structural damage, not just cell infiltration. And this figure is also duodenum. Within the lamina propria, there are markedly increased numbers of neutrophils. This suggests active inflammation, possibly ongoing epithelial injury. So here we're seeing the inflammatory component layer on the top of the structural damage. This figure is the ileum. There's multifocal dilation of crypts. Crypt dilation indicates architectural distortion and regenerative stress. This often correlates with more chronic disease activity. So when you look at these 4 images together, you can see both domains we've been discussing before. Inflammation, such as increased neutrophils, lymphocyte plasma cells, structural remodeling, such as villi atrophy, fibrosis, crypt dilation. And remember, structural parameters often correlate more consistently with clinical disease activity than mild inflammatory infiltrates alone. When you review biopsy images like these, don't just count inflammatory cells. Okay, let's move to case 1. This is a 6-year-old neutered Labrador. He has a 4-month history of chronic small bowel diarrhea, about 10% body weight loss, intermittent vomiting, and importantly, no response to 6-week hydrolyzed diet trial. He had only partially improved with metronidazole. Lab work showed mild hypoalbuminemia, mild hypocobalamin. CDC was otherwise normal. Imaging revealed mild diffuse small intestine thickening, and no focal mass. So clinically, the dog looks moderate severe. We have chronic progression, weight loss, hypoalbuminemia, failure of dietary. That's why endoscopic biopsy of the duodenum and ileum was performed. Now here's where it becomes interesting. The pathology report reads mild lymphoplasmacytic enteritis, minimal villi blunting, no creep dilation, no fibrosis, no lacteal dilation. So the histopath appears mild. And this is where many clinicians feel uncomfortable. How can a dog that looks clinically significant have only mild histopath changes? Okay, this dog appears moderate severe, weight loss, hypoalbuminemia, chronic progression, yet histopath shows only mild inflammatory changes and minimal structural distortion. Why? According to the Simplified scoring study, scientific histopath scores correlate only moderately with clinical index, and the correlation is not strong enough to predict individual severity. This case illustrates that perfectly. There are several possible explanations about case 1. First, functional disturbance, such as motility changes, secretion imbalance, or barrier dysfunction, can produce significant clinical signs before major architectural damage occurs. Second, early or patchy lead disease may be underrepresented in mucosal biopsies. Remember, we are only sampling superficial mucosa. And third, hypoalbuminemia doesn't always require severe structural distortion on biopsy. This case reinforces an important principle. Histopath doesn't function as a symptom scale. A mild inflammatory score doesn't invalidate significant clinical disease. Management decisions should still be based on the overall clinical severity, not solely on the histopath grade. In other words, the microscope reflects tissue injury. It doesn't measure how sick the patient feels. Now let's look at the opposite scenario. This is a 6-year-old spayed miniature schnauzer. She has a 1-year history of intermittent diarrhea. She responds to steroids, but relapses when the dose is tapered. Body weight is stable, appetite is normal, lab work shows normal albumin, normal CBC, and normal chemistry. So clinically, this patient appears moderately affected, but stable. Because of the chronic relapsing course, endoscopic biopsy of the duodenum and colon was performed. Now look at the pathology report. Moderate to marked villi stenosis, trip dilation in about 30% of sample creeps, moderate lymphoplasmacytic infiltration, mild mucosal fibrosis, and no lacteal dilation. Compared to case 1, the structural changes here are much more significant. Yet clinically, this patient doesn't appear dramatically ill, and this is where the conceptual shift becomes important. In this study, villi stenosis, crypt dilation, and fibrosis were among the parameters significantly correlated with clinical disease activity. But remember, these structural parameters often reflect chronicity rather than acute symptom intensity. Structural damage accumulates over time even when symptoms are partially controlled. So what we may be seeing here is long-standing immune-mediated injury, a remodeling process that has been ongoing for months or even years. Histopath may reveal deeper disease chronicity than the clinical presentation suggests. And that's a key lesson. Structural parameters often reflect chronic biological injury. They may not mirror how bad the diarrhea or vomiting is today, but they tell us how long and how deeply the disease has been active. In other words, Case 1 shows us that mild histopath doesn't exclude significant clinical disease. And case 2 shows us that significant structural distortion doesn't always mean severe current symptoms. The microscope shows us biological death, patients show us functional impact, and those two are related but not identical. Now let's move to Feline case. This is an 11-year-old neutered domestic short-haired. He has 8-month history of weight loss, occasional vomiting, mild diarrhea, but appetite remains normal. Lab work shows mildly decreased cobalamin, albumin, and CBC are normal. On imaging, there is mild muscle thickening of jejunum, but no discrete mass. Because of the chronic weight loss and imaging findings, endoscopic biopsy was performed. The pathology report reads marked lymphoplasmacytic enteritis, mild architectural distortion, no obvious epithelial tropism, and no transmural sampling. Now, clinically, there are several concerning features, like chronic weight loss, muscle thickening on ultrasound, and pathology reports marked lymphoplasmacytic inflammation. So the key question becomes, is this IBD or is this early small cell lymphoma? In case this distinction is difficult, histopathologically, both conditions can show dense small cell lymphocyte infiltrates. Architectural changes may be subtle. Unlike canine IBD cases, feline chronic enteropathy lacks strong validated histopath clinical correlation data. So we cannot rely on scoring system the same way we do in dogs. When findings are borderline, additional diagnostics may help, like IPC for CD3 and CD20, PAR PCR to evaluate colonity. These tools can increase diagnostic confidence. But even then, some cases remain ambiguous. And this case highlights something very important. In fact, histopath alone is often insufficient. Interpretation requires integration of histopath imaging findings, clinical progression, and response to therapy. Diagnosis in feline chronic enteropathy is often probabilistic. It may evolve over time. Sometimes the final answer is not just found in a single biopsy. And that's why feline GI disease demands even greater caution and clinical integration than canine IBD. So let's take a moment to highlight the growing value of molecular diagnostics in veterinary medicine. These tools are becoming increasingly important, especially when we are trying to rule out disease that can produce GI inflammation. One example is the Bioguard Qmini system. It's a real-time PCR platform designed for rapid and accurate detection of pathogens. It offers reliable results in a compact, clinical-friendly format, making molecular testing more accessible in everyday clinical practice. Molecular diagnostics can be particularly helpful because they allow us to support that the diagnosis when clinical signs and histopaths are not entirely clear, confirm or rule out infectious causes in complicated inflammatory disease, guide treatment decisions, including antimicrobial therapy or isolation measures. So when these molecular tools are used alongside histopathology and IgG, they help us move closer to a precision medicine approach. By integrating morphology, immunophenotype, and pathogen detection, we can build a more complete diagnostic picture and ultimately provide better, more targeted care for our patients. Okay, thank you all very much for joining today's webinar. I truly appreciate your time, your attention, and your interest in this topic. Even though we are meeting virtually, I hope this session has been clinically practical and thought-provoking for you. If you have any further questions or thoughts you would like to share, please don't hesitate to reach out after the session. Once again, thank you for being here. I look forward to connecting with many of you again in the future. Stay safe and take care of yourselves, and also take care of your patients. Thank you.
And Dr. Chiou, there are some
So
questions in Q&A.
Okay, let me see the questions. Mhm. Okay, I see there's many of you were requesting that of me. Okay, I see there's a question. The question is, why is histopathology often poorly correlated with clinical severity? Okay, the answer is because histopathology measures structure and cellular changes, while clinical signs reflect functional disturbance like motility, secretion, and barrier dysfunction. Therefore, biological injury doesn't always equal symptom severity. Okay, I see another question here is this audience like to ask how about is there any difference between clinical signs of IBD and location of small intestine that has inflammation, and how we decide which small intestine should we biopsy based on clinical signs? Okay, there are some clinical signs related with upper GI tract, like uh, associated with stomach and small intestine, and some signs are related with lower bowel, like colon. In this study, they suggest to biopsy duodenum and ileum if you see the clinical signs are more related with upper GI tract, and they suggest to biopsy the colon if you see the clinical signs are related with the lower GI tract. Okay. So if you are not so sure about the symptoms and there's also association with the GI tract, you can biopsy them all because but remember you have don't biopsy the stomach. You should biopsy the duodenum, ileum, and colon, and multiple biopsy is suggested. Okay. Okay, here's another question is biopsy must be done by endoscopy or can do exploratory laparotomy. Oh, you can do laparotomy to obtain samples because laparotomy is more easy to obtain much more samples, bigger samples. It's a good choice. But laparotomy is need more uh, discussion with the customer. Okay. And there are some questions about the therapy, but I cannot respond to those questions, so I will skip the questions. I think that's all I can answer. So do you have any other questions about this presentation? Okay, if there is no further question, thank you for joining this webinar. I hope you take care of yourselves and your patients. So if you have any other questions, please don't hesitate to reach out Bioguard, and those questions will send to me, okay?
Thank you, Dr. Chiou, for an outstanding
Right.
lecture. And sincere thanks to everyone who joined today's webinar. We look forward to welcoming you again at our next webinar. Thank you and good night.
Thank you, good night.